years, you won't have had a public board meeting opened by the wonderful Julie, who you will recall finished with us at the end of May. I'm Eileen Milner, and I'm the interim chair of CPFT. Very mindful of just how much Julie brought to CPFT and is being missed. And we saw her the other day, and I did sort of feel that sense with her of just how much she was thinking, oh, this is my family, I should be here. So Julie, if you're watching this, we are very much missing you and thanking you again for all that you brought and did to us. We've got the chat function open throughout the meeting. So if anybody's got an observation they want to put in or a question that they'd like to ask, we can't always get to every question, as you'll know. We've got a very busy agenda, but if you do want to raise something, I promise we will get back to you if it's not possible to do it in the body of the meeting. Now we're going to begin today's meeting with noting that we have no apologies. And I'm just going to ask if anybody has discovered they have a new declaration of interest to make that we aren't aware of. I will take silence as golden. We are going to open the meeting with welcoming Anna Forrest, who's going to talk to us about Schwartz rounds and how they are something that is important in terms of the support that we offer in the clinical setting to our staff, and of course impacting on the quality of our care. So Anna, really a big welcome to you. If you want to introduce yourself at the outset, that would be fantastic. We are mindful of the amount of time that we've got available to us, and you've provided a really detailed slide pack, which I don't think we're going to be able to get through quite all of the slides, but if you want to use the time available to talk to us about why Schwartz rounds are important, where they've come from and the impact they can have, and then we'll have the opportunity, I hope, for a few questions. So Anna, over to you.
Thank you. I have got quite a few slides, but I'm quite efficient, so I'm trying to get through them. I'm just going to share my screen if that's all right.
Yeah, they seem to be alive and well, and as Caroline says, if we can make sure that microphones are muted so that Anna can talk to us, and then I can manage any questions coming in. So Anna, over to you.
Splendid, thank you. So I'm Anna Forrest, I'm the psychology lead in OPAC, and I'm currently the interim clinical director, and I'm also the Schwartz round lead for the Trust. So I'd like to start with a story because Schwartz rounds are all about storytelling, and the story I'd like to tell you very briefly is about Ken Schwartz, who's the gentleman that you can see in this photo. So Ken Schwartz was a lawyer in Boston who was diagnosed with advanced stage lung cancer in 1994. He was aged 40 at the time of his diagnosis and sadly died 10 months later. During his treatment, he was really touched by the care that he received from the professionals who looked after him, and he noted that small acts of kindness really helped to make the unbearable bearable. But he noted the impact that it had on staff, and he wanted to do something about that. He left some money in the US that founded the Schwartz Centre for Compassionate Care, and Schwartz rounds started in the UK in 2009, and they're licensed in the UK by the Point of Care Foundation. So roughly, they are a safe, regular, time-limited space in which challenging work experiences can be talked about and listened to. They're held monthly, and they're an open invite to any CPFT staff member who wishes to attend. The benefits for Schwartz rounds are multiple, and they're for the individual who attends, but they're also for the organisation and for our patients, because we know that supported staff give better care. 85% of staff who participate in Schwartz rounds feel better able to care for patients, and really they're about bringing people together as people. So there are studies that have been done on this, and you can find more information about this on the Point of Care website, but they talk about people feeling more connected, less stress, feel less isolated at work, greater sense of teamwork. But the big win for me is about this thing about increased organisational understanding and seeing beyond personal identities, professional identities, because you hear stories at Schwartz rounds that you just wouldn't hear in any other setting. So they're all about promoting compassionate care. They're a non-judgmental, confidential space. They always have this the same format, which has the panel members there as storytellers and the facilitators holding the session. They always have themes, and we're very open to suggestions for themes, and they're non-hierarchical. So we really encourage people to be there as people rather than the roles they do within the organisation. But we're very clear, as per the guidance and the structure that we follow, that they're not therapy, they're not supervision, they're not debrief, and they're not a space to problem solve. They're a space to reflect on what it's like to be in difficult situations. So the timeline for Schwartz round at CPFT, and there were people considering Schwartz long before we implemented them. We've been running them since May 2019, and we started them unashamedly from the OPAC Directorate because we recognised the need, and so we started running them from OPAC with an invitation to the rest of the trust to join us. We started face-to-face, rotating around different locations, but we were only able to get to each locality quarterly. We only had 3 facilitators when we started because we had to start somewhere, and since we've expanded to have 6 facilitators, and we're a really good team. And I just kind of wanted to acknowledge that now we span all of the directorates. We're very well supported by the chaplaincy, and John Nicholson was instrumental in starting the rounds. And we also have an admin person who provides admin support for running the rounds. We had to pause running Schwartz round sessions in person because of COVID for obvious reasons, and so those were suspended from March to September 2020. But during that time, the Point of Care Foundation developed the team time model, which are basically like mini Schwartz rounds, but aimed at teams of people who know each other and work together. And the idea of those were they were to support teams with current themes and issues arising from COVID. So we grew those from May through 2020 and onwards. And then we were able to launch Schwartz rounds virtually in September 2020, which we did with some trepidation, but have really been something that has been a big win for us. Whilst we were developing team times, we commissioned some artwork, which would really to help socialise people, because if we can remember back to the early days of COVID, we had clinical teams who weren't used to online meetings, and certainly the idea of an emotional conversation was something that we needed to help people with. So we got this artwork done to kind of help explain the etiquette of doing meetings like this online. So our progress so far, we're still managing to pull about 50 staff for each of our monthly sessions. Teams and using Teams as a platform for virtually delivering these sessions has been a game changer. It's much more accessible than going around the localities, given the number of bases we operate out of as a community trust. And we're offering pop-up rounds by request, and we're still doing team time sessions. So this chart shows you how we've grown over the years that we've been doing this. So the 2019 figures are only for part of a year because we started running in May. 2020, obviously, we were suspended for part of this, so those numbers only reflect the 4 months at the end of the year. But 2021, peak COVID, our numbers went through the roof in terms of people attending, averaging 58 people per round. And 2022, things have gone down a little bit as services went back to normal coming out of the pandemic, and obviously the data for 2023 is ongoing. This is another one of our pieces of artwork. The team time data. So we ran a lot of these sessions and we were taking requests for this. We plugged this through Staff News and various other formats, and we went where they asked us to go. So we have run 31 team time sessions to date, and we're still offering them now if people want to do these. So you can see these are much smaller groups, generally attended by about 17 people from within a team. This is just to show the range of services who've accessed team time. The first year was still quite OPAC led, but we did have a couple. We did one with the Adult and Specialist SLT and the FENS unit at Whitemore. And then that second year of running them, at that point, we managed to get far more services involved from across the trust. And this was the point where we got more facilitators from the other directorates, which really helped spread the word. Pop-up rounds, I think, is worth mentioning because we've done some interesting things with this. So we kind of consider ourselves friends to the staff networks, and we've really worked hard with them to be a platform for having interesting discussions on themes that they want to draw attention to, really. We did a pop-up session as part of the Leading Together Festival last year about systems without borders. And so we had a mixed group in the audience of people from different parts of the CMP system, which was fascinating. We did one as part of the AHP conference recently on career journeys. We've done one for menopause matters, and we've done some recently as part of the International Day of the Nurse and part of the 75th anniversary of the NHS celebrations. And these are just to give you a flavour of some of the themes that we discussed. And I would definitely note that our confidence in tackling difficult issues as part of Themes for Schwartz has really grown over the years as we've become a more confident facilitator team. We're always happy to take suggestions for rounds, and we definitely kind of encourage ideas as part of the feedback that we get. The reason that I'm really here today, I think, is that I mentioned it to Anna that we had recently done one in May that was a collaboration with Royal Papworth Hospital. Now, Papworth don't currently run Schwartz rounds, but we're really interested in the work that we do. And they asked us to do one themed about neurodiversity, which was something that we were keen to talk about as well. It was a fabulous session. We had over 90 people there. Really good conversation, and certainly Papworth have been keen to talk to us moving forward about if we could do a follow-up event, which we're currently liaising about. Our feedback is consistently good, and so most people would come again, and most people rate the rounds as good. And we just wanted to share some of the qualitative feedback that we have from our attendees, because I think it shows how valued this space is for people. And we do get people from across the directorate, and we do monitor the range of people that we've got in our audience, and we know that we're getting staff from all of the directorates, including the corporate teams. We just wanted to share this, and because it was fabulous feedback. So we, as part of our contract with the Point of Care Foundation, we have a mentor who comes about quarterly to observe a round and give us feedback. We've consistently been praised for our approach to running rounds. She was at the neurodiversity round that we did with Papworth, and I think that the feedback that she gave us is testimony to the team, really. It wasn't me facilitating that day, but the team were fabulous. I'm posting the link so that if you want to find out more about Schwartz rounds, that's where to find it. And thank you for listening. And you have an open invite to come to a Schwartz round, so please do.
Anna, that is absolutely brilliant. And you said that you were very efficient in your use of time, so let me commend you for that. In the chat, you'll see that Rick is saying he's been so impressed with how these sessions have been developing over time. But let's go to if others have questions. Pri, did you want to come in?
Yeah, I mean, I think it's more, sorry, Anna, nice to see you again. First of all, just a massive thank you. One, it was really interesting and you were very time efficient, so well done. Just to say, it's just, from a staff wellbeing perspective, these kind of things are so important. We talk a lot about caring about our people, but actually, you have to be seen to do things. And actually, I think we appreciate in the NHS, you can't just do one thing and expect it to work. But actually, I'm really impressed and surprised at the range of topics you've covered. So it's not really a question, it's more of a well done. But yeah, it's really nice. I suppose one question I might ask you offline is, what do you do if something's raised that is controversial, that raises something that does need to be escalated? But I don't know whether that's something you'd want to answer at this point.
No, I can answer that. I guess we wouldn't encourage people to problem solve in the session because that's not what they're there for. But sometimes the issues come up where we would say, that sounds like we need to have a conversation about it offline. I'll contact you, and we do follow things up. And equally, if we have people who we're concerned about for whatever reason, we always make sure that we follow that up. And certainly a member of the facilitating team would get in touch and get people the support they required if that was necessary.
Lovely, thank you, but well done.
Thank you.
And Anna, whilst we're waiting for somebody else, possibly to have a comment or a question, you said that you've grown from an initial little seed of you to becoming a team of 6 expert facilitators. If there was somebody on here who thought, I'd love to be a facilitator, how, and that would be fantastic, I imagine you'd welcome even more people. How can that happen?
Well, if they contact me, so we've just lost a facilitator who was our sort of representative from the Children and Young People Directorate. We would be really keen to get a replacement for her, because I think if we don't have a foot in all of the clinical directorates, it's harder to maintain our momentum with that. So we will be approaching Head to Toe. I didn't say Head to Toe, but Head to Toe have been instrumental in supporting this, because they funded us setting them up in the first place and have paid for the renewal of the contract and the facilitator training. So certainly we'll be approaching them, but if you did have somebody who was interested, then contact me and we can pick that up.
That would be brilliant.
Certainly, what would be helpful potentially is a member of the exec team being part of the steering group. That would be something I'd be very interested in, and I really sincerely mean, do come to the rounds, because I think it's really powerful having execs and non-execs in the audience, and we would never announce that you're there, but they're interesting conversations, I think, in terms of the tone of the organisation and some of the things that get said sometimes. Equally, I would be very happy to have you as panel members at any time.
Anna, that's brilliant, and I would love to come to a round if we can make sure that we get some invites or know when they're happening. I'm sure many of us who are on the non-exec side would absolutely love to do that and feel privileged to be part of listening. And Anna, I don't know if you're going to respond to the challenge set of having a member of the exec on the steering group, which seems like a really good thing to do.
Yeah, so absolutely, and I'm sure more than one of us would want to do that. I was actually going to make another comment, Anna, and thank you. It was a really lovely presentation, and sports rounds really are good, aren't they? You know, I've been involved in other organisations as well. What I think is really wonderful is that we've had other organisations with us in the system reaching out. So the fact that Papworth has reached out, and we know, don't we, that we're really good at the staff wellbeing things, and we've provided a service in other ways across the system. So it's really wonderful that that's been recognised and colleagues are reaching out to us, and that you've been able to respond to that. So and even more of a rich environment, I think, if we are working with colleagues across the system, because we work more and more in such an integrated way, don't we? So yeah, well done. Thank you.
And I think that there are so the acute hospitals all run Schwartz rounds individually, but there are other, obviously, huge parts of the system that don't have anything like that and things. And certainly nationally, there are some systems that have developed ICS level Schwartz rounds, which I think is a really interesting idea. And a few of us had kind of had some conversations about it. I suspect you need a system that maybe has matured a bit further along the lines than maybe we are at the moment, but it's definitely something that I think could have great value. And the thing about organisational understanding, I think, is the real power for those as a kind of platform.
And that's great, but both Annas, let's make sure that we get a member of the exec on the steering group. That would be a really tangible outcome. We've got somebody on here who's very welcome. They call themselves psychology undergraduate student, so you are very welcome. What are the main issues with those who are attending? What are they mainly concerned with, Anna? Are there some themes coming through that you'd be able to share from the rounds?
I mean, the conversation is based on whatever the theme of the round is about. So people are kind of coming to talk about that issue. But the idea of the session is that the storytellers, the panel members, start the conversation, and then people from the rest of the audience, if you like, chip in, and we have a community conversation about the theme. So I think we talk about all aspects of things, because I think my sort of take on this is that whether you're facing a stressful event and you are working in a corporate service, then that's, we all get stressed about things, whether we work in a corporate service or any of our very diverse clinical services. And I think it's about being there as human more than anything else. And I just think it's really useful to hear different perspectives on things. Certainly, I think there's some insights that you hear at Schwartz rounds that that don't leave you and you need to reflect on afterwards, but that's a good thing.
No, it certainly is. Anybody else at all? And I think we should say an enormous thank you to Anna, and indeed your co-facilitators who work with you, because this is such well, it's a marvellous legacy for Ken Schwartz and his family to have left behind, and the fact that we've picked it up and are working with it, and you've taken it on through COVID essentially, and working with it beyond that, I think is absolutely brilliant, Anna. So my thanks from the board to you and the team, and we'll all look forward, I'm sure, to joining a session and just seeing just the full richness of it in practice. So thank you very much.
Thank you for having me.
No, it's been a real pleasure. Thank you. So let's move along, if that's okay, having had much thought provoked by Schwartz rounds, into the minutes of the last meeting and any matters arising from those. So can I ask if anybody's got any issues, firstly on accuracy of those minutes? And is there any matter arising from them that anybody would like to raise that isn't covered in the agenda that we have in front of us today? Kathy.
Thanks, Eileen. There was just a small need for rewording on page 11 of the minutes, which I'll talk directly to Caroline about. It's just there's confusion between myself and the Deputy Medical Director.
Okay, I'm sure we can sort that out elegantly between the two of you. So thank you for that, Kathy. Let me go then to the action log, where, as far as I can see, Caroline, correct me, there is one action open, and this is to do with how we are analysing waiting lists. Do we have any update on when that? Debbie, did you want to come in?
I can, yes. So that piece of work is being done across all waiting lists, not just physical health. We are in the process of putting what we call PTLs, patient tracker lists, in for each of our services, and physical health piece of work is just about ready to go live, and that will show each of the services how many people are waiting, and what we're doing about that. And I'll come onto it more when I present the IPR later, around the full package about what we're going to do about developing waiting lists and trajectories. So yes, it is ongoing, and I should be able to bring much more detail back to the September board.
That's brilliant. And I know Julie was really good at this. We're all very good at using acronyms that we're very familiar with. Some of them in CPFT I still don't understand. So if we can steer away from them whenever possible, that would be brilliant. Thank you very much, Debbie. We'll look forward to your update a little bit later. So let me begin my Trust Chair's report by welcoming and thanking. So if I could formally welcome Derek McNally in a slightly new role, for a little while at least, as our acting Chief Finance Officer. Derek, thank you so much for stepping up and stepping in. It's hugely appreciated. As I welcome Derek, I do want to record formally the board's thanks and good wishes to Scott Haldane, who was our CFO and did such sterling work over a period of years, which did include being acting chief exec more than once. So this is somebody who's given such great service to CPFT and made a contribution to ensuring that we were operating in a fiscally responsible way. His passion and commitment for the work that we do was absolutely undoubted. Now, because of all that richness of experience that Scott's got, he has now gone over to the Integrated Care Board to help them in terms of planning for how resources are best deployed, and he will make an enormous impact there, I know, as well. But Scott was much missed by colleagues and much thanked by the board for all that he has done, all he's brought, and indeed all he will continue to do in the wider system. So really wanted to just make sure that we recorded that publicly. You have a report from me in terms of what I've been doing as I've been trying to get to grips with some of the challenges of taking up a chair role whilst we move to recruit later in the year to a substantive chair. A lot of that will understandably be about learning about the partners that we work with, building relationships and rapport there, but also, of course, critically getting to know our staff and our services and our service users rather better. So I am making a point of trying to get out as often as I can to do just that. I would want to record a visit to our respiratory services team, which had a real impact on me. They are a small, but I would say perfectly formed little team who provide really critical services to those who suffer from the most serious of lung conditions, and operate right across Cambridgeshire and Peterborough with such commitment and such passion, but actually with such thoughtfulness as well as to how services can be improved for patients. And that is what good healthcare is all about, the passion, the commitment, but also the thoughtfulness about how can we get ever better. So I'd want to thank them because they are part of our physical health service, and we do talk a lot about our mental health services, but remembering that we are also really responsible for keeping people physically healthy and caring for them in their own homes. Which brings me to the need to be thoughtful as an organisation about what we are doing, how we're doing it. Anna is going to talk to you a little bit about a news story about us which relates to a review of suicides, and that's a really important piece of work which has attracted some media attention, and it is right that it should do so. We, as all health organisations should be, are always looking to see where we can learn from things where we could have done better, and where we can find good practice within what we do and what others do to make sure that we are consistently improving. So Anna will talk a little bit about that. And I think we'd also want to reflect on a report that was published yesterday. It got a little bit of coverage, not a huge amount, but I would commend it to anybody who's interested in health, which came from the Health Foundation, and it is looking ahead to 2040 and the impact of demographic changes on the pressures that we're going to find in health. And that tells us what we probably know intuitively already, that demand is going to increase, but 2.5 million more people in 2040, which, given that we're in 2023 now, is actually not that far away, are going to be living with a chronic health condition. And that sees a really significant uptick in areas of health where people are going to need support in the community, physical ill health, and also significant uplifts in people living with mental health issues and dementia. So how are we thinking about that and planning for it now? And being thoughtful and planning in a thoughtful way around how we organise our services to deliver to communities which are as complex and as deserving of the best possible care as ours are across Cambridgeshire and Peterborough is a major part of the work that the ICB is doing, but also that we, as the most significant player in terms of mental health and community health in Cambridgeshire and Peterborough, are going to be really alive to in the period ahead. So I know everybody is busy, but even the executive summary of that report makes a quite sobering reading about what we are facing by way of challenges. Let me just also, by way of a little bit of advertising and encouragement of people, we will have 2 non-executive director vacancies arising in the next 6 to 9 months, and we will be starting a process of recruitment for those in the early autumn. So if there's anybody online who's interested in thinking about becoming a non-executive, please keep your eyes open. We're always really keen to hear from people, particularly who live and work in our area, who might be interested in making a contribution through that route. So be delighted if anybody wants to have a conversation about that. So I suspect you've heard enough from me, and we ought to go on to hear from Anna about the things that are on her mind, which are complex and many, but they almost always are when you're a chief executive. So unless anybody's got any questions for me, and I am happy to take any. John, did you want to come in?
Apologies, Eileen, I won't take long, but it was just picking up a point on your paper, or in your paper, about the anti-racism framework. Just wanted to make the board aware of the work that we're doing to develop a patient and carer race equality framework. I've just recently taken on exec lead for equality, diversity, inclusion. I really want that to feature large in terms of the work that we're doing. It's a really important means of us connecting more closely with our community. Will have a real impact on health inequality, something that we're taking really seriously at the moment. So just to flag that it's there, and we'll make sure that the action plan that we're developing is routed through the PSQ over the next few months. We look to publish a final plan by the end of the year. So it's just to make the board aware that that's happening.
Yeah, no, absolutely important to have drawn that out, John, and my apologies that I didn't give it airtime. So thank you for that. And I think you will be taking this through PS&Q, but I think that we ought to bring this to public board to talk about what we are doing in that respect. So if Caroline can add that, yes, PS&Q, so sorry, the People Safety and Quality Committee. You see, I'm falling into acronymitis. We ought to bring this to public board to talk about what we are doing on anti-racism, but also, as you say, equality, diversity and inclusion, because that does make for a healthy, strong organisation offering the best services to all of our people and communities. Any other questions or observations before I do pass on to Anna? Thank you very much. Anna, the chair is yours.
Thank you, Eileen. So I will take the paper as read, but just to pull out a few things as you've indicated that are in the report, and a few others. So just on the EDI theme, I just wanted to draw attention to a conversation I had recently with our local CQC inspection team, and they've indicated that they would provide us with the opportunity to participate in a pilot that they're doing around how they will be inspecting equality, diversity and inclusion going forward. So obviously I really jumped at the chance of that. So any opportunity to learn some best practice and have some fresh eyes review. I haven't heard back from them yet, but I think we've got a liaison meeting later this week or next week. I'm looking at Penny for confirmation, but she's back from leave, so probably hasn't caught up with her diary as yet. But I think there's an opportunity to chase that through with the CQC to make sure they haven't forgotten us on that. A couple of really important things then. So I really didn't want to gloss over the industrial action that has really impacted the trust and the system during July. So we had 5 days of junior doctor strikes, followed immediately by 2 days of consultant strikes, and then another 2 days of consultant strikes planned in August. Those went really well. Our teams were fantastic in terms of working together operationally, clinically, to continue to provide services safely for those people who urgently needed it. It did mean that some planned activities, so outpatient type activities, were stepped down, but I am really pleased to say that the days went smoothly, but that was not that I don't want to downplay the amount of planning that enabled that to happen. It's been a significant amount of planning over those weeks leading up to that, and we're planning now for the August strikes as well. You mentioned, Eileen, the review that we have commissioned. So just so colleagues are aware, we have commissioned a review into completed suicides going back to 2017, so going back 5 years. And this is in line with the new Patient Safety Investigation and Reporting Framework, so PSIRF, which is the national framework which will be replacing the serious incident framework, which is encouraging organisations to look much more at incidents in a thematic way. So traditionally we've investigated single incidents, whether they be suicide or other serious incidents, as single incidents, and of course there's recognition now that there is missed opportunities there in terms of learning. We are working with some family carer representatives in terms of the terms of reference. We've drafted them, and we'll be doing some more work around those with those representatives, and also how we perhaps contact those families involved in those incidents that we are actually going to review, and then the oversight of that from a board level will be through the Patient Safety and Quality Committee as well. So it's a really important piece of work. We have an ambition, and we are working with the Zero Suicide Alliance, because these are, well, clearly they are our most serious incidents, and the impact is so extensive that we really want to take every opportunity to learn and reduce those incidents to zero. The other really important piece of work that we've become involved in is the right care, right place work. And it isn't necessarily clear what that work is about, but actually it's the work that we are doing collectively with the police around ensuring that those people out in the community who often end up having a 999 call and the police attend, but they may well need other services than the police. So they may need mental health services, housing, social care, etc. So this is a piece of work which is happening nationally. Cambridgeshire is an early adopter, an early implementer, and we're working really closely with Cambridgeshire Police, Cambridgeshire Constabulary on this piece of work. I think Debbie's going to, in a moment, say some more about that, because Debbie is leading that from an executive point of view. And there are some examples elsewhere around the country that, again, we'll be able to learn from. So I'll just update on one more thing, and then perhaps Debbie can pick up around that. So the other issue I wanted to highlight, and you'll see that through a number of our reports today, is around the out of area treatment, so out of area patients. So these are our patients who, because we have been unable to provide them with inpatient treatment within our footprint, so within our trust inpatient units, they have needed to access care outside of the county, and in some cases it's a long way outside of the county. This isn't what we would want for a number of reasons, so we've been really actively doing some work, operational teams, clinical teams, and working with some of our corporate teams to really repatriate, bring those patients back, and we've had some great successes you'll be able to see in the IPR, the Integrated Performance Report, and then also the important impact that will have in terms of our finances, and you'll be able to see that in the Finance Month 3 report as well. Thank you. That was all I was going to pull out, Eileen.
Okay, Debbie, did you want to come in?
Yeah, just to add to the right care, right place, and yes, there's been a lot in the media this morning around that, of how it is hoped that this will be fully rolled out over the next 2 years, but we're in that pilot phase. There's been a couple of workshops with senior clinicians trying to highlight what the task and finish groups will be, and as of next month we'll have our own internal meeting across all the directorates, pulling that together so we're clear we're not doing things at tangents across different parts of the organisation. So that will kick off fairly soon, and as Anna mentioned, we've got really positive relationships with the police, and the way that we're working together is, you know, I know there's been some bad press around this, but actually we're working really positively with the Cambridgeshire Police, so I think that we can do some really good things in relation to this, and making sure that our patients are in the right place with the right people, which is what ultimately this is about. And then just to add to Anna around I will go into more detail about what is happening around the out of area placements when I come to the Integrated Performance Report.
That's really helpful, Debbie. And I think John's just noted, I think right care, right place was covered quite a lot in many media channels this morning. If anybody's interested to have a look at it, there is some sound theory behind it. As ever, it's the practice and sufficient resources that will make this work for real people who are experiencing mental health crises, and we are certainly very thoughtful about that and working well with our constabulary. Anna, did you want to come back in?
Yeah, sorry, apologies. Further down the report as well. So just to point to the quality report later on the agenda, where we've reported that there have been 2 serious incidents during June, and these are serious sexual safety incidents. So there is some further information in the report that Penny will present around sexual safety and the focus that we're having on that, and also those 2 incidents in particular.
Thanks so much, Anna. We'll look forward to hearing from Penny on those later. But right, I think as Chief Executive to draw out where there are serious incidents and indeed just how seriously you are treating them. Did anybody have any questions arising from Anna's report? No. Really helpful, Anna, thank you. And there's certainly, as ever, a lot going on in the world of health to be aware of. Could we then go to the board assurance framework? And Caroline, do you want to take the lead on this one for us?
Yep, happy to, Eileen, thank you. So included within the meeting pack are 5 key documents in relation to the board assurance framework. The first is the risk movement report, which outlines a totality of risks currently recorded on the BAF. And then there are 4 appendices which provide you with a breakdown of each aim and associated objectives, the risks to us achieving these, and the risk detail within each objective, which includes the risk score and the mitigations. As outlined within the report, there are currently 24 risks recorded. 11 of these fall under Strategic Aim 1, which is to ensure we deliver the best care possible. 5 fall under Aim 2, which is to ensure people are at the heart of everything we do. 2 fall under Aim 3, which is to ensure that we are system leaders in innovation and research. And then the last 6 fall under Strategic Aim 4, which is to ensure that we make the best use of system resources. The highest scoring risks to us not achieving our objectives, as outlined on the board assurance framework, are the capacity to ensure that we're able to deliver and operationalise improvements, delivery of the home first model if partners do not engage to ensure its sustainability, the risk of us not achieving quality targets within the commissioned quality schedule, of us being non-compliant with CQC regulations and safety processes, of staff vacancies, fatigue, and our ability to improve organisational culture, and the risk of us not being able to develop and deliver operational and financial targets. I updated back at the last board meeting in May on some of the developmental work being undertaken in respect of the board assurance framework and the organisational risk appetite in conjunction with RSM, our internal auditors, and that work remains ongoing with a further board session scheduled to take place on the 16th of August, and then RSM will join us again at the next session on the 18th of October. So Eileen, I'm happy to stop there and hand back to you for questions.
Thanks so much, Caroline. Gosh, there is a lot in there, and this is the representation of a huge amount of work. So grateful to everybody who inputs to it. I have had one, while people gather their thoughts on questions they might like to ask. Our ever diligent Mike has asked a question in advance, which I think is it really goes to the heart of what we're trying to do here across the 24 risks, which is perhaps possibly best addressed to you, Anna, in the first instance, which is taking the whole. Do you think we've got sufficient resources, capacity, capability to effectively manage and mitigate all of these risks?
Yeah, so I think that's the $6 billion question, isn't it? So the work that Caroline and the rest of us have been doing around the board assurance framework, I think going forward will make it much clearer in terms of how we are having really clear oversight of the risks, what have already been mitigated or partially mitigated, and then what we're focusing on next. And what we're focusing on next will then be featured in the reports, either to the board committees or and or directly to BoD itself, and really using the data to demonstrate how we're making an impact in terms of mitigating those risks. I think at the moment it's fair to say that we have to hunt that through a little bit, you know, which report is telling us that we are having an impact on the risk to which objective. And as I say, the work which Caroline, we should have for a discussion in August, shouldn't we, in terms of, you know, before we bring it to for use in the public meetings. But at the moment, I think it's really hard to answer that question because it's not really clear which action is being monitored where and who is responsible for each of those. The BAF will be clearer on that going forward.
Okay, I suppose if I were to be slightly unreasonable, Anna, and indulge me if I am, it's to sort of say, I mean, the BAF is a summation of some process and analysis that we do. You could take this at a level of, do we feel that we are prioritising our resources into the right places to address known risks, and do we have deficits in terms of skills, capability, capacity in doing that?
So if we think about the staff in order to deliver our operational requirements, well, we know that there's a piece of work happening at the moment, nearly complete actually, around a nurse staffing review. We're going to embark on a similar piece of work around a medical staffing review, which will indicate that we need to grow our workforce in order to deliver what we need to deliver. And as you alluded to, going forward, there's going to be even more demand. So I guess the short answer to that question is no, but we are identifying where those risks are, and then that will help prioritise. I mean, the other example would be around the industrial action. So, you know, as those risks become apparent, then we will prioritise our operational resource to those risks immediately. But what we've got to make sure we're doing is keeping a view on the longer term strategic risks as well. So who is focusing on the immediacy and who's focusing on the strategic? And I don't think that's clear enough at the moment within the BoD assurance framework.
Okay, very helpful. Anybody like to come in on this at all? Any questions at all? No, there's certainly a wealth of information in there. I guess it's what we do with it that now matters, isn't it? So thank you very much, Caroline. I know you and a very small number of colleagues give a lot of your time to these activities, and we are grateful for them. Could we move on then to take from Karen a report on the People, Safety and Quality Committee?
Okay, thank you, Chair. Good morning, everybody. I will take the papers as read, or my paper as read, and apologies for the date error. I guess that's the risk of using the same format time and time again. However, the paper 9A relates to the May meeting, which I'll update you on the couple of points I want to pull out, and paper 9B relates to the June meeting. So what I'd like to pull out in terms of the May meeting, and it does link on to work we're doing later in June, is around the management of risk. We've had numerous conversations, and just to pick up on somewhat was said there by the chief exec about how we manage the risk processes and the requirements to review and strengthen how the organisation is managing risks at all levels. It has been discussed at People, Safety and Quality, and we have requested a risk recovery plan, which has been produced at the June meeting and will be discussed further at the meeting later this week. But it is about looking and identifying and articulating the actions and the processes that go in place to tackle the risk, to make a tangible difference to reducing that risk. And as you can see from my report, there's partial assurance at the moment as to how effective that is. The other thing I'd like to just pull out from the May meeting is the Patient Safety Quarter 4 report. And as you can see, concerns around the increasing incidents for this quarter, which sit within OPAC and Children, Young Person Family Directorate. And a lot of it is linked to falls. There's a fall implementation plan being implemented across clinical areas, but again, slight concerns about whether the learning from what is going on is being implemented in a consistent way to have an impact on the level of incidents across the trust. The carer programme update, which still concerns in this area across the trust. There's a new post in place and an implementation plan. Sorry, I can't talk this morning. But again, there is still some concerns about the consistency of which we are bringing in carers to help improve our business, and hence why it's partial assurance for the May meeting. In terms of supervision and appraisals, we've got the scope for growth policy that was presented to PS&Q in June. I suppose the question will be, is it going to make a difference to the business on the ground? We will watch and see, and in particular the compliance across the different areas of business in terms of the compliance of doing the new appraisal processes and the frequency of them and the difference it's going to be make. And I suppose the question in terms of that policy that we'll be looking at is how can we be assured that the new process is going to give us the success that we're seeking? And again, moving to the June meeting, as I've mentioned, the risk recovery plan was presented. It's comprehensive, I'll say that much. Slight concerns around the timeline for action, October, November, and then beyond into May. But I think what we'll be seeking is assurance that notwithstanding the recovery plan, we are looking to manage the individual risks on a day-to-day and month-by-month process. Some excellent piece of work which has been mentioned already around the safer staffing review that's been done by Penny, and I'm sure she'll talk about that. Excellent piece of work. I suppose the comment that was made in the meeting is we can't unsee what we've seen, and there is a significant requirement of funding in terms of financing that uplift, which we'll be looking at in due course. But PSQ as a committee approved the recommendations in that paper. And I'll stop there for questions, either for me or the relevant executives.
Thank you so much, Karen. I think nobody should be in any doubt about the forensic eye that you deploy as chair of People, Safety and Quality to really doing what a non-exec is there to do, which is to deploy oversight and to bring challenge to bear. I've got one pre-advance notice question, which I'll come to in a moment, but let me go to Debbie and indeed anybody else who would like to come in.
So this is a comment as opposed to a question, just to add, Karen, that the work, we've been doing some work in operations and around the triangle of care and increasing the carer work, and each directorate is coming back later this week with their plan of how they intend to do that piece of work and what it will take. So just to update, that will feed through into PS&Q going forward, but just wanted to let you know that we are actually moving that forward.
Thank you, Debbie. Thank you.
Okay, Karen, can I just put to you a question and say if others have got thoughts, either pop them in the chat or do put your hand up. You're always very welcome. So there was a risk that was reduced, risk 7393, which was around sexual safety reporting, so that we had more confidence in that risk in reducing it. And as we've just heard from Anna, we've had 2 serious incidents in June. Can you just talk to us a little bit about the process of how that came to be, or perhaps Penny would like to come in on that one?
I can take that one. We've got a sexual safety quality improvement programme, which is overseen by our sexual safety task group. We have implemented training. So currently, I know the quality report says 61%, but we're currently higher than that. So adults and specialist mental health will reach the 95% target by the end of August. And we have now broken that data down by wards to focus on that more. We signed off our sexual safety policy. So we've made quite a lot of improvements in people's knowledge, but also process. So prior to the incidences happening, because of all that improvement work, we reduced the risk. Given the fact that we've now had those incidences following that reduction, obviously at the next sexual safety review group, we will need to consider that risk in more detail. We have learnt some lessons, particularly action to do post-incident that has been updated to our policy, and that will go back through the ratification process. So immediate learning has been done. But yeah, the process is that it was reviewed prior to the incidences occurring.
I'll just go to Karen as chair and then I'll bring Anna in.
And notwithstanding what Penny has said, I think in terms of managing risk and the recovery plan, I think from our perspective of Pearson-Q is notwithstanding the knowledge upload we give to staff, the processes, procedures and policies that we put in place, and thus some excellent work done there by Penny. It is, are we sure we are managing the risk at an operational on the ground level, and where is the evidence for that to be updated on the risk register so we can then reduce or increase the risk based on the evidence of what is actually happening on the ground. And that's what I will want to see in terms of the recovery plan and in terms of what the updates on the risk register are, because there's a lot of process updated on the risk register, but what about what is actually happening and the evidence that is then presented on that paper?
I suppose just kind of responding to that was, we obviously look at all of the incidences. You'll see in the quality report that we've put an SPC chart in there. So we have had increased reporting because the awareness has increased through the training. But what we haven't seen is the moderate and above. So we hadn't seen that up until the two incidences that had occurred at the end of June, beginning of July. So that was the difference, I guess, and that does change our risk appetite now and our risk scoring. So yeah, so looking at our clinical incident report, and that's also taken into consideration.
And just for the benefit, my benefit, what's an SPC chart, Penny, before I go to Anna?
Our statistical process chart, so it looks at trend analysis as opposed to just month-on-month variation.
Okay, all right, thank you. Anna.
Yeah, so it's just building on what Karen was saying. I think really there's some learning for us, I think, in terms of, you know, we could really demonstrate and measure the inputs we had made, but what we've seen, certainly with you know, recent instances, that kind of theory practice gap. So, you know, how do we know that every member of staff really understands the changes that we've implemented and that they are doing those consistently, and what might be the barriers to them being able to do them consistently? And I think it's a fair challenge to say that we reduced that risk prematurely when we weren't certain that all of those new changes were embedded. And I think there's some learning there in terms of how we look at our risks across the piece.
I think that's a wise reflection, Anna. Thank you. And just to say, on appraisals, Kathy, you shared with me really helpfully that the appraisal rate for medics has increased, which is good, and that you've got a plan to do more on that. Do you just want to mention it?
Yes, so we have now an 85% compliance, which is a good improvement on medical appraisals. And we're in the process of implementing iteratively an electronic system, which is going to link appraisals, mandatory training to salary increments, so people won't get their next pay point if they haven't completed their mandatory training and their appraisal, which is actually quite a useful incentive. It will also be looking at prompts. So at the moment, it's very much up to consultants to remember when their appraisal is due, and medical staffing who, you know, are hugely busy sending reminders by email, by looking at spreadsheets. So we now will have an electronic system to automatically prompt people so that they've got time to prepare for their appraisal and to organise it in a timely manner. So I think this electronic system is going to be really useful, but it's just going to take a little bit of time to roll it out. We've already got things like annual leave and study leave logged, and that's proving very helpful in terms of coordinating.
Excellent. That's great to hear. And if we could spread out that prompting to all of our staff, that would be real progress as well in terms of incentivising us also. So thank you. Karen, is there anything else you'd like to say about people's safety and quality?
Not at this stage. We'll just keep on moving forward and making a difference, hopefully.
Yeah, no, keep on keeping at it. That's brilliant. Stephen, did you want to come in?
Yeah, thank you very much, Eileen. It's really just to reinforce what Kathy was saying, that the notion of appraisals and the notion of increments, etc., that's already in place for Agenda for Change staff. The medics are now doing what the Agenda for Change staff already do. We've discussed that previously at Pearson-Q and at board. And I think, you know, what's really interesting for me around appraisals is that we are seeing some movement. So, for example, Children's, Young People and Families Directorate are currently at 70%, which is really, really good. I think there's a challenge for corporate services and their appraisals. So there's some work to be done there, actually. And MI Reports, which is a really helpful reporting tool that we use behind the scenes. Everybody has access to that. That now gives you down to individuals where appraisals are sitting, so you can access that via the Trust intranet, and that's on there, and you can really see some detailed information of you know, some of those areas that really do need to focus on the new appraisal process, supported by that scope for growth policy.
Okay, now that's a good reminder that for the bulk of our staff in Agenda for Change, which will be our nursing staff, our AHPs, that exists. Thank you. 70% is good, but not great. So, you know, I am just encouraging still more that an appraisal is something that everybody should be doing. It's not really an optional extra. So thank you. If we can get those moving still further, that would be great. Any questions before we move on to the quality report? In which case, Penny, your moment in the sun.
Thanks very much, Chair. So take the report as read, just some key highlights. You'll see that our trust quality accounts for 22-23 were published in line with the national deadlines. You'll also note the significant improvement that the team have been working over the last year in addressing backlog of complaints. As you can see now, we have 10 at the end of May. And not only have we reduced the number of backlog, but the number of days of overdue complaints as well. And this has been achieved through investing in our complaints team, revising processes and working with our service users around how we can be leaner and more responsive in our complaints. You'll also notice the big improvement we've also been working in terms of dealing with clinical incidences that are reported. So the numbers that has been reported remain fairly static, but we're now up to about 86% of dealing with them within 30 working days, which is a massive improvement from 4%, which is the starting point. And we've also had a massive improvement in addressing overdue and backlog of clinical incidences as well. So at the end of May, we had 365 clinical incidences that were overdue. And that's a massive reduction from over 2,000, which was our starting point on our journey. So really commend the team on that achievement. You'll have heard the reference to the inpatient nurse staffing establishment reviews. That was presented to PSQ, and we're hoping to bring that to Trust Board next month, following further discussions with the team around how we implement those recommendations. We've also completed a review of learning from a historic eating disorder. So this is again picking up the new methodology that the Patient Safety Incident Response Framework is advocating. So changing the way that we have our learning and ensuring that there's continual learning. So that was reported to PSQ, and we will report again in a couple of months' time, an updated position. Anna spoke around our quality improvement project around suicides, which obviously is a dramatic impact on people and really tragic. So it's really important that we maximise our learning to inform our quality improvement programme, and I won't add any more to what Anna has spoken about. You'll notice from the quality report, we've also strengthened our patient safety metrics, and that's evolving. So we still have some more metrics to add to our quality report, but we wanted to increase the spotlight, and that's part of our response to Edenfield, but also evidencing our compliance around the Use of Force Act. And again, we are working on further metrics that we need to do with the latter piece of statute. I've referenced it through the meeting, but we have been leading a quality improvement programme on sexual safety. So I've alluded to the fact that our policy has been developed. We're looking at, we've commissioned external training. We're on target in adults to award 95%. There are some hotspots, and we want to pick those up in the performance meetings moving forward to give real focus on them. And we're also working with our regulators and our ICB colleagues around the investigation of those two serious incidences. Another exception to note around the mental health metrics is that we've just had a spike in 1 month in terms of prone restraint, which is 6 cases. All have been reviewed as they should be. 3 of them were due to administering medicines, and 1 of them was a service user put them in that position. All of them lasted for less than 2 minutes, but all of them have been reviewed, and we obviously try to reduce and eliminate prone restraint as much as possible. The Patient Safety Incident Review response plan has been approved. It's on target to meet the deadlines for our ICB submission. So they're the key messages from our quality report, but I'm happy to take any questions.
Thanks very much, Penny, and it is encouraging to see some areas of progress. So our thanks to teams who are working hard on doing this. But anybody like to come in with any questions or observations for Penny, or indeed other members of the team? I think, Penny, you've given us such a comprehensive report, and that people are alive to the issues that you're raising, some of which we've covered previously, as you say, but others where I'm sure everyone would join with me in being encouraged by some of the progress that we're seeing. I am particularly seized by our commitment to patient safety and the way in which Henrietta Hughes is leading on this agenda nationally. And we want to become exemplars of really learning and encouraging a culture of learning from where things go right, both at ourselves and in other places, so we can improve, but also being honest and open enough to learn from where things have gone wrong, because that's what good organisations commit to do. Debbie, did you want to come in?
Again, just a comment about how we're tying all this together with what's happening at an operational level. So as Penny's mentioned, we monitor most of this, or all of this actually, through the performance reviews that we do with the directorates. We're now pulling that out where we've got key areas, and the triangle of care being one of those, and really then having some concentrated discussions with the operational leads about what plans need to go in place and how we can work that through on the ground with staff. So just to tie it across of how it's all linking together.
Okay, and that of course is so important, Debbie, making things join up. Ed.
Thanks very much, Penny. As I've commented before, I do like these dashboards. I think it's very helpful to see the data and to see the trends. The question I had, or perhaps it's just a request for comment, is what we're seeing is kind of like trust-wide metrics, and I'm thinking, are the safety risks or any other performance metrics homogeneously distributed across the whole patch? Or to put it another way, would it be useful to see the data with a bit more granularity, perhaps, you know, in relation to particular teams, particular centres where we think there might be special safety risks?
Yeah, I think that point's really pertinent, because we do know that trust averages can iron out and level out hotspot areas. We do look down at a directorate level, we do look down to a ward level, you know, when we picked up prone restraint, or you can see the self-harm, for example, this month has gone up. That's largely down to some individual service users and the risks that they're very complex. So we can actually go right down into that granular detail. We do put some of that in the narrative, but what we can do is, where there is an issue, we can then lift it up, put it in the exception report, really focusing down, so we're cognizant of where our hotspots are across the services.
Thanks. If I might just come back, Eileen,
Yeah, please do.
it's very reassuring. I'm just wondering, in terms of board assurance, is there a way that we could see that level of
yeah, we can work on that,
you know,
not
like
a problem.
a map of the county or something, you know, something quite, I don't want to micro design the graphic, but I'm just wondering if there's a sort of a fairly efficient way of just showing us every month or thereabouts, if there are hotspots emerging, anything that the board ought to be aware of, as well as your team.
Yeah. So there's one way that will be coming, which went into the Safer Staffing report, which is at a ward level, that triangulation between staffing and quality. So that's one way we can do it, but we certainly can look at other ways how we report that while still protecting sort of confidentiality as we go right down into detail. But absolutely happy to look at that.
Well, I think it's a great suggestion in terms of Ed, and that allows us to see variation, which is often where the key might be. So Anna, let me go to you, and then to Debbie, and then I'll come to Rick's question.
Yeah, thanks. Brilliant observation, Ed. And actually, Penny, you alluded to it with regards to the sexual safety training, and when we start looking at that at ward level, and you know, appraisals, everything is very much, it can be hidden in that way. One way which absolutely will give us that level of oversight is one of our quality priorities, which is around the ward accreditation programme. And as we start to build that up and then start to take all of our ward areas and then eventually other teams and community services through that accreditation programme, then we'll have a really good way of understanding where some of the hotspots might be, where areas may need more support. Now, obviously, it's going to take us a while to build that up. So I think, you know, Penny's absolutely right. In the interim, we can look at how we can make that clearer, and it might be through some of the deep dives that we do through the committees. I think we can work through that. I suspect Debbie's going to talk about what we've got available in performance already.
All right, Debbie, we'll come to you, and then Penny, if you can also be having a little look at Rick's question and be ready to respond to that. So Debbie.
Yeah, so just we're doing a massive piece of work with the performance team at the moment. For those that don't know, in light of the changes with Scott moving into his new role, performance now sits with me. It's an interim position, but that's helping us to tie together all of this and how we actually start to re-look at the performance report and how we can really start to do that drill down so that we can see it clearly. And it's, you know, obviously we need it for assurance, but also for team managers, service managers and such to use as management tools to work with their teams to be able to spot these trends, dig down and work it down to actually a clinical level, clinician level, to see if there are any issues or whether it is a patient issue, as in, you know, with the prone restraint, whether it's one individual or lots of individuals, and is it around a package of care or is it around an anomaly. So all of that we're really working on, and I'll talk a little bit more as we come into the discussions around the integrated performance report, because it should all tie together and it should have all of this in one report at a point in time when we get there.
Okay, we will look forward to that, Debbie. So Penny, Rick has posed an important question about how do our number of sexual safety incidents that we're reporting, how might they compare with elsewhere? Are we an outlier?
So at the moment, we can't get that data. So there has been some national research work that has been undertaken looking through the clinical incident NRLS, which is the National Reporting Learning System. And that is really difficult to get any kind of reliable comparison data due to different people measuring different things. What I can say is when we've done the deep dive around the sexual incidences, of a significant proportion of these relate to historic disclosures that may be sexual incidences that are outside of a healthcare setting, but they've been reported using the Sexual Safety Code on our clinical reporting system. Learning from patient safety events, or LFPSE, does give us an opportunity to explore the data in more detail, or definitely have much more around protective characteristics and helping us really drill down on some of these issues as well. But at the moment, we can't do that baseline. I think also, from my understanding, is each mental health trust is at a different a part of their quality improvement journey around sexual safety. So awareness and reporting is at different stages of evolution as well. So I think that's another factor within this. We did expect reporting to increase as we raised awareness, which is what you tend to find on any kind of training around safety issues, I have to say, not unique to safety, sexual safety. So we kind of do expect to stabilise and then get a true baseline, but I think there is something about, have we got the metrics right? Do we need to break it down to, are these current sexual safety instances, and whether this is historic disclosure, and how we can get our clinical incident data system to be able to pull that out. So I still think there's more work that we need to do on really understanding our picture.
Yeah, and I think probably some work to do nationally to feed in as well, Penny, around how because being able to make comparisons, so you understand whether you're a good performer or an outlier for more negative reasons, is something that can only help to improve. Rick, did you want to have a supplementary?
Well, yeah, it might be easy just to say it rather than type it. Can I just tie this back to, because I seem to remember last year that the CQC issued a warning against us, and we had to do something around reporting for sexual safety. I think that's right.
Yeah, so that was in relation to that there was an incident that occurred in an inpatient environment that wasn't reported to the CQC. And because it wasn't reported to the CQC, that triggered what's it called? Inspection. I've forgotten the word then. And so that was the background to that. There are mandatory things that we have to report to the CQC, and that wasn't undertaken. And I don't understand the detail behind that. Obviously, that predates me. What I can say now is that we are in regular contact with our CQC relationship managers, and they are kept up to speed with all sorts of happenings that are going on within CPFT through regular meetings. And we obviously inform them of the recent two instances. They have been fully informed of those instances.
So the bit I'm struggling with is what you just said about there's no kind of national data we can see the scale, relative to other people. But if the system that we use for monitoring and reporting goes to CQC, and presumably everyone has to do that, then the CQC must have that data to be able to provide comparison. I don't understand how that cannot be the case. So,
Rick, CQC publishes something called a State of the Nation report in respect of health, which will have some trend analysis. But as Penny was alluding to, there are many, many things that CQC takes reports on. And I suspect this is one area where there is more work to do as a system about getting a collective baseline as to what we are measuring in the first instance. So that consistency of what is defined and what is measured, how it's reported, and then how you can understand as a trust that wants to improve how you can understand where you measure up against others and where places are that you might want to go and look at who are doing things well, and where you have others where you know, you are performing well yourself, so others might want to come to you. So I think there is more work to do nationally and locally on this. Karen, did you want to come in?
Yeah, I think just picking up on Rick's point, this conversation I just had earlier with Debbie is notwithstanding the systems and processes nationally or even regionally aren't in place, but whether or not there's an opportunity to just have conversations with counterparts about what is your sexual safety activity on your trust, but also as a ICS, sexual safety can't just be relevant to our trust, it must be relevant to acute trusts. Where does it stand in terms of the ICS and other hospitals and other trusts in the county to get a conversation going there, to get a sense of where we do sit, but what other learning we can pick up from them? So I suppose the citizen process might be there, but picking up the phone and having a conversation might give us a heads up to answer Rick's question.
No, that's an excellent, very pragmatic approach. Anna, do you want to come in, because you've been in and out in terms of hand up, hand down, and then I'm going to go to Penny, and then I think we're going to have to move on to the infection control report.
So the situation is that there isn't a requirement for trusts to report in a standardised way sexual safety incidents. So that's why it makes the benchmarking difficult, but absolutely not impossible. And as we are part of a provider collaborative in the East of England region, we absolutely have the opportunity to compare ourselves to similar trusts. The types of incidents in acute trusts are very different, Karen, so it wouldn't be comparable at all. Different client groups with different vulnerabilities. What there is the opportunity to get involved in, and we are taking the opportunity to get involved in, is there is a national quality improvement initiative being run at the national level by the chief executive who leads for mental health at the national level. So that's Claire Murdoch. And members from that national team, and they are also working with the HSIB. So I'm looking here so I get the acronym right. So it's the Health Services Safety Investigations Body, and that was originally brought in to examine maternal and neonatal deaths, but that's now expanding and will also be looking at mental health inpatient wards safety and quality. So I think that's a real opportunity, and actually we are engaging in that. Penny is engaging in that with her team, so we can influence some of that in terms of what sort of things do we feel we need to be looking at a national level, and clearly sexual safety is one of those things we would want to influence there. You're muted, Eileen.
That's always the best thing to do with me, is to mute me. Thank you, Anna. I suspect you said most of what Penny was going to say, so she's taken her hand down. Much to do here, and much to report on, and we are doing so transparently, and really want to keep at this because it's a very important area about the quality, safety and effectiveness of our care, which at the end of the day is what we are here to do. So let me continue, Penny, to let you have a light upon you with the infection prevention and control report.
Okay, thank you. Again, take the report as read. I think there's one key bit of information just to highlight, and that is that we had one case of hospital-acquired C. diff. We have had the scrutiny panel, and we will update the PSQ next in this Friday, but just to give some assurance that appropriate measures and management are in place for that individual case, but we'll give more detail in the next infection control report. But happy to take any questions around the rest of the report.
Thanks so much, Penny. I'm assuming that the individual concerned is well now.
Yes.
Good. It's a horrible thing. Any questions for Penny? All right, so we'll let Penny have a moment off, and we'll pass to Stephen to talk to us about the People and Agency Exception Report.
Thank you very much, Arlene. Well, like everybody else, I'm going to take the report as read, but there are just a couple of really sort of key areas I just want to pull out from the report. First of all is sickness. You'll have seen that's reduced to 4.12% below target, and actually I can report in June it's gone below the 4%, which again is incredibly positive. And just to align it to a system discussion that we just had, you'll know in CPFT we currently have a very healthy health and wellbeing team, and there's further information in the report. There's a system team, and also we provide a mental health team. The feedback from the system has been incredibly positive on our mental health team that we do, and there's a bit of a conversation on around sort of whether we can extend that. So I think it's really positive for CPFT, and obviously our staff also use that mental health team as well. And clearly, as I say, sickness has reduced and continues to reduce quite significantly. I mean, the other bit just to draw out then is it would be remiss of me not to just mention the long-term workforce plan that came out. It is a 15-year workforce plan. We will bring a paper to PS&Q. It will go for obviously for Trust Leadership Team, and that'll be our formal response into the workforce plan. And we'll bring that to TLT, Trust Leadership Team, and then we'll bring it to PS&Q and subsequently BoD, because I think BoD need to be cognizant and cited on that. And that talks very much around, 15 years worth of clear focus on workforce. It talks about training, additional training places. To give you an example, at the moment there are currently 6,400 nursing associates. They're talking about 64,000 nursing associates by the end of the plan. It talks about retaining, and it talks about a lot more work around retaining people in the NHS, and it also talks about reforming the NHS around workforce planning and also around digital and delivery, and that clearly has a huge impact upon clinical operational services, etc. And it talks about some new roles. So for example, and again, it talks about sort of a medical type apprenticeship role as well. So it is quite radical. And I suppose the final point around the plan is it talks about 2.4 billion worth of investment over the first 5 years, and it'll be reviewed every 2 years. And it's clearly the first time that we've had this sort of breadth and depth of a plan, and certainly you can go on NHS website and have a look at it. It's 150 odd pages in detail. We're expecting a lot more guidance to come down around that. So that is incredibly positive, and we'll bring a paper to Trust Board. And then my final point is that our vacancy rate has reduced overall to 8.1%. However, I think it's fair to say, a bit like an earlier conversation and perhaps what Ed, you were saying around levels of granularity of some of the data, clinical directorate's vacancy rates at 10.5%, and that does hide some challenges we got around inpatient wards in particular. And we had a broad conversation yesterday, our Trust Leadership Team, around what else can we do in relation to staff and staff support, etc., and that reward and recognition piece. And you'll recall last year at BoD we had a long conversation around that. We did a reward and recognition sort of update for the organisation as a whole. We're doing further work around that, and again the paper talks about certain elements of that as well. I will stop and happy to answer any questions.
Thanks so much. So I'll go to questions. Kathy is noting that we might like to take a presentation on the staff mental health service. I'd certainly think that would be a great idea. I think we ought to take this opportunity to thank all our staff for what they are doing. These have been, for all sorts of reasons, very busy times, and I am constantly struck by the huge levels of commitment and pride, indeed, that people bring to their work, even when times feel a little bit tough. So Pri, let me go to you, and then we'll go to Ed, and then to Jeff.
First of all, thanks, Stephen. I mean, there are some encouraging signs there, which is helpful. This wasn't the question I was going to ask, but actually I have done a service visit with the staff mental health service, and they do amazing work. And actually, I think the one thing they raised was just that they want as much visibility as possible. And I think I assume all that those kind of services always say that, but I suppose it's just always challenging ourselves to make sure that everybody's aware of it as well as has access to it. But that's a small point. But yeah, they were an amazing team. It was really impressive. So my question is sort of following on about the vacancy rates. And again, Stephen, really pleased to see it dropping down, but it is still high. And I think 2 points. One, you made the point that it does hide, that 1% hides things that, not necessarily hides, but slightly disguises things that we need to dig into. I guess my question is, are there any themes across the directorates of why we're struggling? I know we could all do a broad brush answer to that, but I guess I'd like to know for CPFT, are there things that you're seeing and that would help us to do things differently or to know where to invest more resources?
I mean, look, again, Pri, I think that's a really, really good question. So a couple of things come out, certainly from some of the work we're doing around that sort of that broader induction into CPFT and that hybrid working and all of that work. And again, there's some further information on some of those key projects. So there are two things. First of all, there's a cost of living issue. It is causing significant challenges for our staff, and that's one of the reasons why we have, certainly from an inpatient perspective, agreed to pay a retention premium. I have to be quite clear, it's a short-term retention premium, and that certainly will be communicating out across the organisation within the next couple of days. And again, there's a bit more of a conversation in the organisation about that. And then the other thing, I think, what is causing some challenges is the pressure. And we hear that a lot from ops around, it continues to be very busy. It continues to be quite challenging on the wards. The levels of acuity continue to be quite high. And that's not just inpatient services. If you go and talk to our sort of district nurses, for example, you go and talk to our PALT and CALT teams, that's the Peterborough Adult Locality and Cambridge Adult Locality teams, they will continue to say to us that actually it is hot within the system and it is quite challenging. And that's why it's really important to link what we're reporting here to some of the work that Penny and Kathy are talking about around sort of staffing levels. Have we got the right staffing levels? Have we got the right skill mix? Have we got the right sort of people in the right place? And that needs to be drawn together in order to try and mitigate some of that. So it's acuity and challenge, but it's also cost of living here as well in Cambridgeshire in particular.
Thank you.
Great question, thank you, Pri. So we'll go to Ed and then Jeff and then Debbie and then Brian.
Okay, so Steve, you've got a lot to look forward to there, but let me just kick off. And my question probably overlaps a little bit with Pri. I just wanted to pick up on the break glass shift curve. And just, I suppose I'm really looking for a bit more narrative around what do you think changed sort of round about autumn 2021? It seems to sort of jump up and it still looks as if it's still rising against a target of 0. So it seems like there might be some kind of strategic factors there that are driving that or that are going to need to be addressed. And maybe it does come back to the staff review and some of the things that have already been discussed. But I'm just curious to have a bit more narrative around that trend.
I mean, that's a really good question. Again, if you go back to 2021, people were still sort of, going through COVID. We had a good tranche of people who basically said, it's been really difficult in the NHS. I've stayed during COVID. We saw quite a large exit of people, and therefore and that wasn't just specific to CPFT. So we had a huge challenge, and if you go to the Institute of Employment Studies, there's a big piece of work that they talk about people not coming back to work as well, and that's around bank and agency and everything else like that. And so actually what you suddenly had is a much smaller workforce. We got reservists that we brought in who were then going back out and, into sort of what was perceived as normal life slightly post-COVID, though in 2021 we were still in COVID. And therefore actually we saw a jump. We saw a certain jump in sort of, bank and agency. I think to mitigate that, if you look at our fill rates around bank in particular at 91%, it's the second highest it's been since we started recording it. So I think there's some positive stuff there. But in relation to your question, certainly was driven by significant sort of exit from the NHS in particular.
Did you want to come back in, Ed?
Yeah, just one quick follow-up. So, I mean, if there's a strategic shift out of the NHS, I know I'm going to ask a question which doesn't have an easy answer, but is there an equally strategic response that we can think about that's going to that will redress that balance?
So if we go back to my previous point around the National Workforce Plan, that was one of the challenges around the National Workforce Plan, because at the moment we're currently using as a nation around about, say, 25% people coming from overseas, international recruits, in order to fill that void. The National Workforce Plan, and again, its level of granularity is fascinating. As I say, we'll bring a formal paper back to board, but it shows you how many more nurses, dentists, doctors, etc. by year, and how they want to work with HEIs, which is health education institutions, in order to try and deal with that gap. It's not going to be a quick solution though, and so that's the reason why in the plan they talk about productivity as well. They talk about better use of digital, better use of AI as well, because there isn't necessarily going to be huge amounts of people coming through in the next sort of 12-18 months. To train a doctor, we know that takes a significant period of time. To train a nurse, 4 years, or an apprentice, apprentice or nursing associate can be 2 + 2. So it's not a quick solution, Ed.
And these are the very, very real problems we face against that backdrop that I mentioned earlier about the health projections to 2040 and just what the need is going to be. So we're going to have to be imaginative, but also talking up some of the positive things. We can dwell on things that go wrong, but being able to talk positively about working in health and care is something I think that we've all got a duty to do, and there are some fantastic stories to get out there, but we need to be able to enthuse people to think about building careers or returning to careers or retraining to come into health and care, because there is so much that is good that can be done. So Jeff, do you want to come in?
Thank you, Arlene. Just a comment really, the element that you mentioned, Stephen, about the health and wellbeing team, mental health and wellbeing team working within the system. I just wanted to say that's fantastic to hear, because we know that the system as a whole, as it was being formed, was asking very directly for CPFT to play a wider role, partly because they sort of the glue within this system within Cambridge and Peterborough. So that's really, really great to hear. I do feel, looking outside the trust, there's still more work that can be done outside even of the health system, in terms of providing specialist resources into all sorts of areas, particularly corporate areas, that would allow us to some extent stem the tide of the demand patterns that we've been talking about. Appreciate that's a bit further down the road, but it does look like an enormous and growing opportunity. The other thing also to say is that what's really great about that is that from all the work that's been going on around collaboration, it's one of many things that we need to do to overcome the demand challenges of the future. It's really great to see that people understand now that collaboration within the whether it be within a provider collaborative or whether it be within the system, isn't something that's happening to somebody else, done by somebody else. It's actually the constituent elements of the trust and our staff and teams that are delivering that. So that was really great to hear.
Fabulous. Can I go to Debbie, and then we'll go to Brian, and then Kathy, and then I think we'll have to move along.
I just wanted to refer back to Pri's point around our areas. Stephen alluded to the fact that we do have high acuity and high caseloads in areas, which is very stressful for staff, and that does lead to them wanting to do different things, and we get into that vicious circle. The less staff we have, the harder it is for those that are left, and we've been really trying to break into that. So we've across the directorates pulled together a small group of people who've been working really closely with HR, just to really try and understand some of that, work on the job descriptions, and look at how we really get into some of those recruitment events to sell what we do, and to sell it in a more positive way, as you've just described, Eileen. And we've seen some success with that. We've certainly seen some success on the recruitment for inpatients and the Mulberries. The trick we've got now is making sure we keep those staff and we support them, because what we are hearing is that now across our inpatient units, I'll refer to particularly, is that a lot of new staff have come in, so they're less experienced, and how do we support them, make sure that they're getting the right training, the right support, and they're feeling that they can stay with us rather than coming and going really rapidly.
Yeah, no, that's a point really well made, Debbie. Let me go to Brian.
Yeah, I've just got 3 points to make, really. I think one of them is that I work with a number of other businesses and organisations, and each of them has seen a slowdown in the number of leavers in the last 2 or 3 months. I think cost of living being the reason that's most frequently cited. So I think that's a trend which, you know, it's hopefully will help and will continue the trend that we're seeing at the moment, but maybe for the wrong reasons. I thought Ed's point, if I could just really go back to that and really support what you said, Ed, because I think we see the sort of the broad numbers, but at specific levels. And we know, for example, things like Mulberry, we had to close a ward partly because we didn't have sufficient staff. We know there's serious issues about the number of health visitors that we have to support the children's activities, and even things like the emergency response vehicles. We've had to take those out because we can't staff them at the moment. So what we're actually doing is we're really challenging our ability to deliver on some of the services that we as a trust are meant to be delivering on. So at the broad level it's a number, but at a specific level we have no vehicles going out, and I think that really trying to get some focus on that, I think, would be really helpful. And I think side by side with that, the break glass point, I think is an interesting one too that Ed raised, because I just would question, and maybe this is something for you to come back on in due course rather than maybe answer now, but when we've had an issue over the last 12 months around the number of out-of-area placements that we've been placing, and there's been a substantial cost to that, and recent activities and the focus that that's been given in the last couple of months has helped reduce those numbers probably by 2/3 from what they were. I wonder whether the same level of focus on something like break glass shifts could also, and it's not the same level of cost that's in the organisation, but given that we're behind our budget at the end of 3 months, I wonder does the level of focus, with a higher level of focus on this, produce some similar results?
Yeah, really good points, which I'm sure Stephen will come back on as we let him finish off. Kathy, did you want to come in?
Yeah, thanks, Eileen. So 2 areas just to mention. Firstly, in response to Pre's comment about staff mental health service and wanting more visibility, I think one of the things is we have a staff wellbeing service and we've got a staff mental health service, and people tend to conflate the two. So the staff mental health service, which I was involved in setting up during COVID, is the one you visited, and that provides secondary care interventions to staff across Cambridgeshire and Peterborough, and has, you know, fantastic outcomes. And in fact, having fought very strongly for our second round of funding, the HR directors in the system are now asking, is there any way we can sustain it long term? So, you know, that's a really good success story, and the team work really hard and have actually, you know, won a number of awards. So and are producing papers for publication as well and presenting at conferences. So just to say, there is a difference between the two. The staff wellbeing service is great as well, but I think people think it's one and the same. So I just wanted to clarify that. The second point is really relating to both Ed and Brian's points about the break glass shifts, and specifically what I can talk about as medical. And I was going to mention this when Derek gives his report in relation to agency spend, which is one of the key pressures currently on the trust expenditure. So firstly, a little bit of context. I link up with all the mental health medical directors across the UK, and this is a universal problem. You'll see in the slide pack that one of our ambitions is to get the agency rates down significantly. But what we're seeing is we're currently breaking glass and paying, you know, 120, and I think we've gone up to 140, say, for a consultant per hour. I've got colleagues across the country who are now paying 180, 200. And I think what we really need and what we're talking about is a concerted approach where all the trusts get together to really put pressure on the agencies to reduce what they're asking for. So at the moment, it's a seller's market. You get into a position where you are desperate to keep services safe, and essentially you are competing with your neighbours to get staff in, and are forced into a position of breaking glass quite frequently. What we're doing is we have just had approval via the execs and the people board to employ a fixed term medical workforce planning lead, and also we, through another educational route, are getting a fixed term medical leadership development lead. And what we're hoping this workforce planning lead is going to do is to look at our current establishment against the current needs. So we know that there's a gap there. So we've had no real review of a medical establishment for a long time because those posts are embedded within the directorates. And then we're looking at projected need over the next 5 years. So going to Eileen's point, we aren't going as far as 2040, but we are going 5 years ahead. And we've got some very good data from Catherine Faulkner, who's doing a lot about the mental health needs across Cambridgeshire and Peterborough. So we've got a lot of demographic data. So we're going to be able to do some projections based on that data about what we're going to need in terms of workforce. So that's really exciting. And going back to Brian's point, Anna's suggestion was that we put this and frame it as a SIP programme. So we're going to look at the expenditure on agency locums and how we can bring that down and actually bring a very razor sharp focus on it by involving our PMO colleagues and this workforce lead, and actually framing it as a SIP, because the amount we're spending on agency locums at the moment, this is really an invest to save project. So
really helpful, Kathy, and this is, I think, work that we would all hugely welcome. Stephen, did you want to come in?
Well, I think Kathy's covered off most of what I was going to say. I mean, I do think we need to report back to board on very specifically around bank and agency. So that's not just the medical component, that's the whole. We had previously switched that on and when we got into quite a challenged sort of time, we then switched it off when use of bank and agency reduced. It's now back incredibly high. It's not just specific to CPFT, obviously, it's a broader national challenge, as Kathy's just outlined, but I do think we should start sort of doing a separate, more detailed report to board, especially given the impact around the finances as well. And within that, we can actually talk a little bit more about some of that broader work that Kathy's alluded to as well, but also some of the work we're doing around nursing. I mean, I do think there are two very distinct things going on here. There's something about the core vacancy rate at the moment, and then there's something about getting the right staff, the right skills for the needs of the service, the clinical needs, the operational needs. So it's about just drawing that all together, and I think that's really quite key.
Okay, Stephen. Well, look, we are hugely reliant on our people, and so therefore it is right that we give a goodly proportion of our meetings to talking about them and to thinking about how can we respond to what in recruitment terms is a hugely competitive market for talent, but also, as I said a little bit earlier, the challenge of encouraging people to enter the pipeline that will be the skills that we need for the future. So we need to see this as a whole life cycle. I did say at one point during that discussion that we ought to thank all of our staff. I think we should also call out that some of our individual colleagues and teams have been nominated for awards, national awards. So that speaks to the depth of quality people we have. And if anybody had the opportunity to hear Trinia Conlon, who is one of our advanced nurse practitioners, speaking when she received her award from the BBC All in the Mind programme, and it was put to her, what you're doing is exceptional. And her response was, but it's what we do. And this, working in health is about making the exceptional normal and real. And we've got to really celebrate that and to make people feel valued, which when you're busy and pressured is a difficult trick to pull off. So if we could move along, because we've got some really quite substantive items to get through. And the next one then, Jeff, would be with you, the report from the Business and Performance Committee.
Thank you, Eileen. So in the interest of time and make sure we've got enough time for discussion for the chunkier issues, I will be brief. There's taking the report as read. There's just really three quick points. One is that we, just for the board to understand more broadly how committee meetings are evolving, pre-lockdown, we seemed to be, we were very Elizabeth House focused in truth, but that's where we seem to generate to congregate for all of our meetings. Obviously, lockdown has meant that we have meetings such we have here, which are efficient, but also have some things that you don't get from being in person. So thanks to the work of Caroline and also the digital team, we're now getting back into using the resources we have in the trust, which is enabling us to have hybrid meetings, not everywhere, but we are alternating between Teams-based meetings and then into hybrid. The most recent one we had in the June business performance meeting took place at the Cavell, where we also have those hybrid facilities. And I think it's part of recognition that as committee chairs, but in terms of a lot of the corporate stuff we do, that we also need to be visible outside what is inevitably a slightly Cambridge-centric, or can be a Cambridge-centric trust at times. So that was just to reflect on how the actual physicality of the meetings is developing. The only other 2 points have sort of been raised already and are going to be covered. Mike raised a question about out of area placements, and Debbie's touched upon that and is going to cover that off in terms of the integrated performance report, the IPR. The other position is that you'll see as you've read through the report and the finance report is that we are in a significant position of deficit. We were at month 2 for the June meetings. We had April and May's management accounts, and we were at a significant deficit position. Position the trust hasn't been in certainly all the time I've been in it, and that has now increased further in terms of month 3. There are some very clear national issues around that, but there are also some specifics around being a mental health and community trust that also apply. And of course, I'm going to defer to Derek to talk you through that in more detail during the finance report. So if there aren't any other questions, that's really the quick summary of BNP for business performance for the June meeting.
Really helpful, Jeff, and as you've alluded to, we're giving lots of thought to seeing how we can get back into a rhythm of people seeing people face to face, but also not losing sight of the benefits that technology has brought to us around being able to be more inclusive. And those are the right questions to be asking about how we meet. Can I just ask a question, which is not necessarily for you, Jeff, to answer, but around Mulberry, which we have referred to, about when that's going to reopen so that we will get some bed capacity back, which will link to our out of area need, I suspect. Debbie?
Yep. Mulberry 3, the patients that were on Mulberry 3 moved back to Mulberry 2 last Tuesday, and Mulberry 3 is just having a bit of a tidy up, I should say, as we've moved out there, and we will be bringing patients back in. Mulberry 3 will open on the 8th of September, and then we'll be bringing patients in from the middle of August, and we'll be fully open from the 8th of September, all of the beds. So we will be back up to our current situation, the full situation with all of our beds. And I'll add into that the out of area placements, which was part of the question I think that was submitted, is that as of Friday we had 28 out of area placements. Unfortunately, that's gone up to 31 over the weekend due to a number of admissions that were required, but we now have more robust processes in place for ensuring that those patients will come back as soon as possible. Just to note that we do currently have one room out of action following the incident at the weekend, which was one of the reasons one of our patients had to go out of area. So that's where we're at the moment. The trajectory is that we are heading for 0. That is what we are hoping for by the end of September. They are on track as a directorate to deliver that, but there are obviously lots of things that could happen between now and then around the requirement for numbers of admissions. But the work that we're doing behind the scenes is to ensure that we've got the right flow through all of our wards, working with the local authority and with the reintroducing the 333 model, hence why we've managed to reduce the numbers in the way we have over recent weeks.
No, that's great. I mean, clearly having a view as to what our sufficiency is, i.e. the capacity we need right across the system, but particularly for inpatient beds, is going to be key and critical for us establishing just what size and shape we should be and what the financial resources we require to back up those needs. Any questions at all for Jeff before we move along? All right, in which case, Derek and Debbie, I give you the floor. and look forward to you introducing to us the integrated performance report.
Okay, so I think I'm picking that one up, Derek. And I'm hoping you'll do the finance piece. The integrated performance report is still work in process. I know we've done a lot of work to develop the performance report over the last 18 months, and I guess we're going into the next phase of that now. So as we're starting to get more information and more data out of our system, so going forward, just to say, you will see more charts and actions, and they will be linked to our performance reviews that we have with the directorates. Probably less narrative, more about where we are and timescales for recovery. So just to update on what's happening within operational services, just to give you a quick view, we have had some move around of staff. Adele has now left the organisation as the director, operational director for adults, and Elaine has moved into a secondment working with John. So we've had 2 vacant posts which have been filled. We have an external permanent appointment to the adults, which we're just progressing at the moment. And Nicola Kershaw, who many of you will know, who works on our who leads our improvement work, has been successful in the secondment into the Children and Young People's Directorate and will take up position from next week. We have, as of yesterday, replaced Nicola. I won't say anything more about that at the moment because we're just working through the HR stuff for that. So we have managed to do all of that backfill at the moment. So those will be new people you will see around. Highlights from the report, just to say the supervision app is now ready to go. We're just finalising a date for launch for that for early August. We just need to ensure we've got the right comms around that and the right guidance in place for staff. So just to give you further update on that. The Healthy Child programme, which has been a concern for some time, have now received an option appraisal, which I believe went to the Children's Partnership Board yesterday. And we're just we'll need to look at that through the PRE. And I know that the Penny and the equivalent in CCS will be having some discussions around how we could potentially make that work to have that going forward. So just to say that was only received yesterday, so that's news off the press in relation to the Healthy Child programme. Waiting lists, we're having some really positive support from NHS England, who are supporting mental health trusts with looking at their waiting lists. It's not something mental health trusts have dealt with, and mental health and community trusts have dealt with in the way that the acute hospitals have. So we're using lots of learning from NHS England, and they've been working with all 3 of our directorates to help us look at our waiting lists. We come to the conclusion we really need to go back to basics, and that's what we're going to do over the next 2 months, and I alluded to that earlier, and we will be able to present the outcomes of that and a much clearer picture from the September board. So we will be looking at those waiting lists, be really clear on the guidance that sits with them. How are we meeting that guidance? Having those patient tracker lists for all of our services, cleansing that data, making sure we've got the right people on the waiting list, having a refresh of the access policy across our services, and the harm review policy that we have that sits behind those waiting lists. So all of that work, it's a big ask to push it all forward during the next 2 months, but we are determined that we will move on this as fast as we can. Out of all that work, we will then be setting performance targets against all the waiting lists. We'll still be doing the capacity and demand work behind the scenes, but we want to start to set those targets to see how we can bring those weights down and where we may get to a plateau. Working really closely with the System 1 team to do that, and with the training team to ensure we've got all of that in place, and we need to do the communication around that. That was all agreed yesterday. So from a waiting list perspective, you will see some very different data with trajectories as we go forward. I think I'll stop there and see if there are any particular questions.
Can I just check, Caroline, you had your hand up briefly, but no, you don't want to put your hand up.
Sorry, Eileen, no, that's an error. I'm just trying to admit Andrea Hill into the meeting. She's in the lobby, but we can't seem to find her.
No, bless you. That's fine. Let me go to Anna and then Brian.
Thanks, Eileen. I just wanted to reiterate what Debbie was saying around the waiting list work and the detailed piece of work that's going to go there. And there really hasn't been this level of detail before around our waiting lists. And, you know, it has really been prompted by the acceleration in the extent of growth that we've seen. I think it would be really useful for B&P to have a deep dive into that area to really understand what it is we are required to do, what it is and how we should be measuring, and then what it tells us, and then a discussion in terms of, so then what do we need to see at B&P and what do we need to see at board going forward? And I think that it's inevitable, as with any of these deep dives, that what we will see will be maybe quite different to what we were expecting. So I guess it's just managing those expectations in terms of, you know, the really deep look could well identify some areas that we will then need to put some real forensic focus onto in order to improve those waiting lists and our collective oversight of them.
Okay, thanks so much. I mean, I think we've had a bit of a theme about definitions today and clarity about you know, the NHS working through, probably having focused for most of its life upon acutes. Now thinking about what does a waiting list look like, what does a target look like in the context of mental and community health, which are just so important. Let me go to Brian and then to John.
Yeah, thanks, Eileen. I think I'm delighted to hear what you just said, Anna, because I think this was as Debbie described it, you know, what was clear was that it was the start of a process which may lead to a redefinition of what the size of the real waiting list should be. I think it's really important we don't lose sight of understanding what the before and after will have been, and how and what the difference is, because I think we just got to be careful we don't run the risk of looking like we're trying to manipulate the numbers to make them look smaller, because I think that's not in anyone's interest. The idea of a deep dive in this, I'm fully in support of. And again, you know, what's interesting is that, you know, picking up my earlier theme, we've just talked about doing a deep dive around the glass ceiling. We did it, which we've just done a deep dive, or we're in the process of a deep dive on out of area, which has been very successful. What this sounds to me, maybe there's a more general point, which is that now that we're starting to deep dive into some of these things and expecting very different outcomes from maybe what we might have seen before, I think what it says is that we get a lot of data, and it's our understanding and, you know, the sort of the penetrating view that we need to take to get to the bottom of what it actually is telling us and what constructive actions we can take off the back of it. If there's a theme here this morning, maybe that's it. And I think that there's no room for complacency around data, and everything you've seen this morning would support that conclusion, I think.
Indeed. As you say, there is a bit of a flavour today, isn't there, Brian? John, shall we pull you in, and then to Debbie, and then I think we'll have to move along.
Thanks, Ian. It was just a question in relation to the out of area placements, Debbie, and I was just thinking, I was talking to some staff members at Cavell this week who are working on that, and it's great to see the reduction. I was just wondering, are we doing everything in an IT system sense to support that reduction? Because the target of getting to zero at the moment on something that does feel quite manual at the minute in terms of approach. I just wondered if there's anything you could add on that.
Yes, so the teams have been looking at an electronic solution to that through System 1 and having its own particular patient tracking list. What we're creating and will go live in August is a virtual ward which will hold all of our out of area placements, so that we can see where they are, when they went, who's overseeing them, when reviews are due, and then more detailed clinical information behind that to understand if those patients can come back, or if we need to support their discharge from their out of area placement. So that will be up and running fairly swiftly, so that's a real positive. I guess just wanted to come back on Brian's comment, if that's okay, Eileen.
Yes, of course.
just been really clear out. You know, I would the last thing we want to be doing is having a view that, you know, that the data's been manipulated in any way, shape or form. So we will be really clear if there are changes in our numbers, why that is, if it's double counting, if it's a patient no longer needs care, or if you know, occasionally on some of our waiting lists we do have deceased patients on, particularly on our OPAC waiting list. So we'll be able to be really clear on that. So it's not a case of just the numbers have come down and it's changed and aren't we doing well, but actually what we've done behind it all, and we've been really clear about that.
That is brilliant. If I could just indulge myself, and this is something that Anna and I've talked about, which is about the Healthy Child programme, where I must confess to having, I know this is where we work in partnership, really significant concerns about health visitor provision and to newborns. And I think this is something where we need to be working with our partner on this to say, actually, this is an area that needs significant improvement. Debbie, I'm sure you would not disagree with me on that.
So just to come back on that, the proposal is a joint proposal between our partner, and they're proposing how they would work with us. So it's how we work together to ensure that we meet the needs of those children, because absolutely those newborn assessments and the Healthy Child programme is a key piece of work that we need to ensure we're delivering in the best way possible.
Yeah, and I'm grateful to you for pushing so hard on getting some data around performance on that, because I know it's been difficult, so thank you, but really important. I think the board will want to know that progress is being made there. Could we then, with everybody's permission, move on to Derek? We've talked a little bit about finance, but Derek, let's talk a bit more about finance in the context of your report.
Okay, thanks, Eileen. Yeah, as Jeff has previewed, we've got a deficit of £3.1 million at the end of Q1, which is sort of moving into uncharted territory for us, as you know, we've certainly not been in this position this early in many of the years previous to this. We've discussed a number of the key factors during the course of this meeting. I think the out of area treatments, we've talked a lot about this morning. It's really positive to hear the numbers that Debbie's quoting as being out there today. Certainly we had something like 70 out there in not that long ago. So to get it down to the levels quoted today, and for that trajectory that's being discussed, we should start to see the impact of that on the finances fairly quickly during months 4 to 6. The other area we talked about quite a lot this morning as well is the medical agency cost. Cathy's outlined the plans to help us address those. I think the lead-in time for that will be slightly longer, but we should start to see some impact of that later on in the year as well. I think in the month 3 position, we had the impact of the NHS pay award. Now it's quite a complex pay award that's been given out this year, and I think we're doing some further work just to validate it, but we reckon that we've got a cost pressure as a result of the pay award, just due to the weightings of how the national funding compares to our weighting for staff. So the national funding for the pay award is 68% of staff. Our national weighting of staff in terms of the proportion of the cost base is nearer 76. So there's a bit of an issue there that we need to unwind and have a discussion with the ICB around whether there's any solutions to that. So we will progress that and see if we can make an impact on that. I think the other part is around the efficiency plans. We need to do further work on those to just crystallise what we will really deliver from those plans in the course of this year, and where we're not going to deliver the plans as had originally been outlined, to put in place the mitigations which will help us offset that. I think the system's in a deficit position at the end of Q1 as well. The system's got a deficit of £11 million. As a result of that, there's a significant focus both by the regional team and the national team. And actually there's a meeting later today which I will attend on our behalf with the regional team, and one next Monday with the national team, where we'll be reviewing our positions and looking at how we can, as a system, try and ensure that we come in with the plan that we've got in place, which is to break even. So happy to try and answer any questions.
Sorry, really helpful, Derek, to understand why we are where we are. I'm going to go to Ed, and then I don't know if you've had an advanced question, but I will put it to you if you've not had it, Derek. So Ed.
Thanks very much. So thanks very much for the summary, Derek. I just wanted to raise, I mean, when we talk about budget deficit and the focus on cost pressure, of course, there's also the possibility of income generation, which could be by various mechanisms, but I suppose I think in the first instance about our estate and whether there's more that we could do there, or perhaps we are already doing, that might be income generating in some way. And I just wonder, where is it, you know, is it perhaps worth sort of capturing for the board in some way on a regular basis what we're doing on the sort of upside of the balance sheet, as it were, as well as on all the good work that's going on in terms of cost control?
So we do have some income that we generate from our estate, but actually, I think as you're alluding to it, it's not a significant element of that. Estate is one of the key areas where I think there are opportunities, possibly not particularly for us within CPFD, but for the system as a whole, which will then help address some of the system deficit that we have, because we do know we've got duplication in many places because we work right across the system, and we know that there are costs being incurred by ourselves and other parts of the system, which perhaps could be rationalised if we looked at it more strategically as the Cambridge and Peterborough ICB. So I think there is a work strategy to look at that as part of the work that the ICB is currently doing. But yeah, it's a very valid point around what we can do to look at some of the upsides that we may have.
Thank you so much. And income generation is something that I know you are alive to, and indeed colleagues are alive to, in terms of other opportunities we may have. And that is the right thing to be looking at when we want to deliver ever better services for all those that we have a duty to care for. Anna, do you want to come in, and then Kathy, and then
Yep.
I'll...
Thank you. Yeah, just to expand on that a little bit. So there is one of our 6 golden thread programmes, which is part of our trust-wide improvement programme, is around income generation. And you're right, there are a number of things around the estate that we could do, but also the wider system could do. We've now got Scott in that brilliant role for the system, which will be looking exactly at those kind of opportunities, not just in terms of, you know, how can we have greater economies of scale, but also how can we have greater income generation opportunities. So one of the things which I've done before and worked really well, and I know we're looking at, for example, is around the use of photovoltaic volts, so income generation from the energy of the sun, which we can then sell back to the grid. And we've got loads of estate that we could potentially put those solar panels onto. So, you know, it's those sorts of things that we can look at, which could even impact us this year if we get our speed on.
Okay. All the necessary permissions being in place, I feel duty bound to say. That's great, Anna, thank you. Derek, just to say, we had a request in terms of the next board meeting, if we could make sure that we were in a position to forecast for the outturn for the year, which I suspect you'd be doing already, thinking about the provisions we've got in place and the use of reserves policy. And a bit more forecast on efficiency savings.
Yeah, and those will be issues which we will be taking through the Business and Performance Committee as the appropriate trust subcommittee to review those.
Yeah, as I say, these are things you would be expecting to do in any case. So thank you very, very much for that. We are 2 to 3 minutes ahead of schedule, which is always great. But Kathy, I know you've got Malcolm coming to join you, who is the project director for the Children's Hospital. Are you happy to start? Or?
Well, I'm just going to ask Caroline to call him in, because he is actually waiting to be called in. Are you there, Caroline?
Hi, Kathy. Sorry, I'm just on the phone to Malcolm. He's just having a few technical difficulties accessing the meeting. He's just trying a different route.
Okay, fine. I'm happy to. So basically, this is an update for the public board, and I suppose it's very nice to end public board on something which is very exciting, which is the Children's Hospital. And just to say, we're making very good progress. So the paper basically gives you, reminds you a little bit about what our aims are with the project, which is really the integration of physical and mental health care to really bring about better outcomes for children and their families. To integrate the CCRI, which is the Cambridge Children's Hospital Research Institute, which will basically really optimize the outputs of research from psychiatry, pediatrics, and the two working together, and translate those into rapid benefits for children and young people on the wards and beyond, basically. We also have a very strong focus on our regional offer. Now, this is something which I suppose the mental health element is a little more complicated because we're already regional in respect of the provider collaborative, but we are already doing some pilot projects, for example, supporting hospitals around the east of England looking at functional symptoms in children, which requires a joint physical and mental health approach. So that integration element, really upskilling and supporting our regional partners. There's some of the kind of key benefits that have been outlined there, but for this group, really the compelling element is the fact that we've sold the Ida Darwin site, and we will need to re-provide those wards. And so that's very much in our mind, and it's very helpful in terms of trying to focus the timelines of this project. Just a reminder that we got planning permission in March 2022. Our outline business case has now been submitted to the regional team at NHS England. They're looking at it and commenting, and will help us to get the outline business case in a kind of shape which is hopefully going to maximise its target of getting through the Joint Investment Committee in September. And once we achieve that, then we're on to the full business case, which will be the next major milestone. The major risks, as there'll be no surprises here, costs and funding. So obviously we've got inflation as a major issue, but we have worked very closely with NHSE to come up with a revised plan, which involves a lot of value engineering and looking at other sources of income, which has significantly closed that funding gap, which was due to inflationary costs. And obviously keeping the programme to time is the other major challenge that we have. So I'm not sure if Malcolm has joined. Sorry, Malcolm. I was entertaining everyone whilst waiting for you to get onto the call, but I don't know how much you've heard and what you might want to add to that from your perspective. Can I just say Malcolm has joined us as a relatively new programme director following Alex White, and his skill set is very welcome for this stage of the programme. You might want to say a little bit, Malcolm, about your previous experience and why you're the right man for the job now.
Well, Malcolm, you have really truly been set up there by Kathy, so you're very welcome to join us. So Kathy's given us a good sense of where the project is at and some of the challenges being faced, but also a sense of gateways to be gone through. So if you'd like to pick up from there, that'd be fabulous.
Thank you, Chair. The danger always in following Kathy is she covers it off so comprehensively that you end up feeling that you're not needed. But I think I just sort of emphasise what she said. It's very, I think from a mental health perspective, and I'll come back to why I'm sort of interested in that, is I think this is really exciting in terms of what we can do in that joint care and the immediate needs of the trust in terms of the Ida Darwin unit as well. I put in the report, just to add on to what Kathy says, quite a lot about the research, because I think it's a research element which can easily get overlooked. But in the appendix there for people to read through is some of the exciting research that's going on. And as we say, we want to be able to develop the different areas of research, particularly those areas into mental health. As I said, the outline business case is due to go to the centre this week, which means that we are on track for its consideration this autumn as planned. So that's good news as well. In terms of my background, I'm a rare beast in that I've worked in the acute physical health sector and the acute mental health sector on operations as a director of operations, and I've also helped in some of these projects for building for mental health facilities as well as physical health facilities in the development of business cases and service change and development. So the idea of being able to work in both arenas is very sort of attractive to me. I sometimes feel that I'm a Google Translate when people talk about PICU. One part of the system says it's a paediatric intensive care unit, the other part of the system saying it's a psychiatric intensive care unit. I must admit I still tend to look for the a suite for calming people down rather than looking after children, but I've got to learn that it's a children's hospital and we've got to do it the other way around. So that's my background, and as always I'm happy to not only brief board members, but also experience of taking this sort of information to governors as well, who I know will be interested, if that's helpful for people.
Malcolm, I'm absolutely certain it will be. I mean, this is amongst all the day-to-day challenges that we face, a children's hospital for our area, our region, our nation is something that is hugely important and can offer inspiration and hope as well to people. So I think we should be really proud of the work that Kathy and colleagues have done over time, and grateful to you now for joining the project. We will want to stay close to this. I know that governors will be really keen to know how the CPFT part of it is being brought together with the physical health side. I think that is part of our value proposition, is that we're trying to do something that has rarely been tried before. We need to think as a board about how we delegate to those who are sitting in steering groups on our behalf authority to help get things done. Sometimes it will need to be pacey, but we also need to make sure that we've got sufficient oversight of what is a major project for us also in place within CPFT, so that we are making sure that our service planning is connecting into that. So there are some governance and oversight issues for us to grapple with. Jane, who is one of our governors on the call, has said that she would thinks governors would love to hear from this about the project. So we will make that happen. But any questions or observations that anybody would like to raise on the Children's Hospital? Ed, let's start with you.
Yeah, so thanks very much, Kathy and Malcolm. And I just wanted to chip in that Kathy and I were in a meeting with QDAR and ACT, so the two agencies that are leading the philanthropic fundraising component of this. And obviously things have been a slight hiatus waiting for the government funding, but I came away from that meeting really quite cheered. They're pretty bullish. There are a number of prospects looking quite positive, and they also emphasise that in their conversations with potential philanthropists, one of the messages that resonates best is the whole child, this kind of concept of integrated physical and mental health care. And as always, we were advocating to make sure that CPFT is at the table and is properly represented in those discussions, not just because of our own self-interest, but because I think we actually add something to the value proposition. And the last thing I'll say, and we come back to this a little bit later for information, and the head to toe charity, one of the things we are hoping to do, particularly as the campaign moves into its public phase, which I think is planned for next year, is for us to become a much more active partner in the charitable fundraising activities, which I think we look forward to actually as a sort of development opportunity. working alongside the much more established fundraising team in ACT. But I think it'll be a great opportunity for us to contribute to the cause.
No, absolutely. And I think you are right when we look at some of the major foundations and philanthropists. The interest in mental health has increased enormously. So we should not be anything less than confident about what we bring to the table. And if I could just talk about how amazing new facilities for children can be. I went on a visit a number of years ago to the new Alderhay Children's Hospital. It's not so new now, but I had the chance to meet with staff, children and families who were being served by a new building. And buildings and environment can matter in terms of the way in which you're able to focus on the child, the family, the integration of care. So that is what we're aspiring to do here, but we're aspiring to do something even more ambitious. So let's make sure that we are doing everything we can to support it. Any other questions or observations? This is something we're going to be hearing about, I hope, lots and lots in very positive ways over the next few years. So I think, Malcolm, we will look forward to hearing from you. Welcome to our family here in CPFT. And Kathy, ongoing thanks to you for all you are doing around this. It is hugely important. Thank you.
Thanks, Chair.
And Malcolm, thanks for fighting the technology to get in. Hopefully it'll be easier next time.
Hope so too, yes.
All right, that's perfect. We have a very neat segue to an item which is a paper for information, but Ed, perhaps you'd like to mention it, which is about Head to Toe, the charitable funds. Just give it a little plug, really.
Yeah, right. Yes, thanks, Eileen. So you can see the paper in front of you. I mean, we had a very useful meeting in June. I'd like to thank the Neds and others who turned up and weighed into that discussion. It was very helpful. The team found it very supportive. You can see the two things we're going to work on are sort of our strategy in general, and I think that's going to include some slightly more ambitious, big ticket type targets, Cambridge Children's being chief amongst them. And we're also going to have a look at the finances and make sure that we're optimally using the money we already have, and certainly not disadvantaging ourselves in terms of competing for external grants, because it looks from an external accounting perspective as if we're better off than we really are. So there's a couple of pieces of work there. I met with Hannah and Alex a week ago, and we are going to work over the summer. We have another meeting of the committee in September to look at the strategy and the finances, and then that's something I'd like to bring back to the board if there's time on the agenda, so that people can see a slightly bigger picture of how we intend to develop the charity. But yeah, I think it's exciting.
Yeah, well, thank you to you, Ed, for the commitment you show to that, and to Hannah and the team. They do great work. We need to be able to elevate the stage on which they play and the amounts which they're able to generate for all aspects of our work. So I look forward to that. Caroline, do we have any use of the trust seal? We do it rarely, but we'll note that we have none. Can I just ask if any questions have occurred to anybody that they haven't got round to asking before we move to conclude? Well, can I end by thanking everybody? Oh, did you want to come back in, Ed?
Yeah, sorry, I seem to be talking quite a lot, but I just wanted to say, because we often moan about the papers at the board, but I just wanted to say that they are increasingly accessible and tractable to me, and I think it's because of the way we're using the data in the reports. And I know we've talked again about ways that could be further improved with greater granularity and so on, but I just wanted to feed back to Debbie and others who've obviously been doing a lot of work on this. Your efforts are much appreciated, and it is easier, I think, to understand what's going on than it was.
Well, it is great to take a moment to reflect, which is, as colleagues know, is what I do like to do at the end of meetings usually. Debbie, did you want to come back in?
Just to say thank you for that. That's really helpful, and I will feed back to the team, because it's actually the team, the performance team, and the Holly and Louise behind the scene, who are really pulling all this together in a different way, and I know Penny's team are doing similarly with theirs. So yeah, I'll make sure they all get the feedback on that.
Brilliant. And positive feedback is hugely welcome. Well, any feedback is welcome, but good to have positive feedback occasionally. So can I say thank you to everybody for their contributions today. You've certainly made it easier for me to be able to get us towards conclusion relatively on time. And I will look forward to seeing you all again in September, our next meeting. If anybody's got any thoughts about how we can improve things, then I'm always really happy to hear from you. So thank you so much, and I'll see some of you a little bit later. Take care now. Bye. Years you won't have had a public board meeting opened by the wonderful Julie, who you will recall finished with us at the end of May. I'm Eileen.